what do we attach that focusing element to that will hold it in place in the front of the eyeball that the body will accept as part of its own?
Welcome to Season 6 of EyeCan, a podcast about ophthalmology through a uniquely Canadian lens. EyeCan is co-hosted by me, Hady Saheb, and Heather O'Donnell. Throughout the season, we'll have guest co-hosts for some of our shows. We will share our experiences as ophthalmologists today and tackle some of the challenges we face as healthcare providers. Season 6 of EyeCan is brought to you by Astellas, Pharma Canada, and Johnson&Johnson Vision. We thank them for their support. In this episode of EyeCan, we explore Osteo-odonto-keratoprosthesis, or OOKP, the remarkable tooth and eye surgery offering hope to patients with severe corneal blindness. We discuss how the procedure works, who it's for, and the challenges and future of accessing this highly specialized care here in Canada. Our guest on today's episode is Dr. Greg Moloney, who trained in ophthalmology at Sydney Eye Hospital and completed fellowships in both oculoplastics and cornea at the University of British Columbia. He has been the recipient of several awards for clinical corneal research, including the Ron Jans Clinical Corneal Research Award in 2012, the Askers Film Festival Cornea Refractive Section First Prize in 2014, 2015, 2016, and the Troutman Prize from the Cornea Society in 2018. He was lead surgeon in the Sydney Keratoprosthesis program from 2014 to 2021 and convener of the DMEC course at the Sydney Eye Hospital from 2015 to 2020. He now lives and works in Vancouver and is clinical associate professor at UBC. Dr. Moloney, welcome to EyeCan. We're really pumped to talk about this fascinating surgery. So thanks for joining us.
No, thank you very much for the invitation.
So this is definitely one of those procedures that sounds almost unbelievable. I'd say still unbelievable to me when you first kind of hear the term. So let's try to start simple for our listeners. So for anyone hearing tooth and eye surgery or OOKP for the first time, what exactly is this and where does it fit into the spectrum of corneal disease?
I think, it is an odd sort of sounding operation, and it takes a while to explain it, even to our colleagues, to be honest. But it's not a new surgery. It's been around for a very long time. And I think you could sort of classify this as, the last resort of a corneal transplantation. It is kind of it doesn't have any different goals than a regular corneal transplant does. Those goals are basically to restore a clear window at the front of the eye to allow light transmission to hopefully a healthy retina and a healthy optic nerve. But we use this in situations where we know that a regular corneal transplantation will not work, and even more basic forms of artificial corneal transplants or keratoprosthesis will not work. This is really for a very, very severely affected group of patients at the heavy end of the spectrum of corneal blindness.
Interesting. So can you go through what actually happens during the surgery? So how does the tooth help to restore vision in this surgery?
Yeah, I think the way I describe it to patients is to say that, starting from a conceptual point of view, if we have severe corneal scarring, we're trying to recreate a clear window. And most artificial corneal transplant surgeries or keratoprostheses long ago figured out that the best material or way to do that or to use to create that window is PMMA, or a plastic that also forms, the basis of intraocular lens design a lot of the time. Recreating the sort of optics of the cornea and the lens and focusing light with a PMMA telescope, or let's call it a telescope. It's not a telescope, it's an optic. Recreating that is not that difficult. What is difficult is, what do we attach that focusing element to that will hold it in place in the front of the eyeball that the body will accept as part of its own? And in our entire body, the hardest sort of substance that the human body produces is dentine. Dentine is not designed to turn over. Once we produce our adult teeth, they are supposed to be with us for our entire life. Dentine is solid. We can drill a hole in it and we can glue that optic or that focusing device into the center of that hole. So the concept we're using here is in patients who have a severely damaged ocular surface that has no tear film, that is dry, heavily scarred. Putting corneal tissue or regular transplantation is something like trying to plant a flower in a desert and expecting it to grow. It just won't grow. And the analogy I often use for my patients is the tooth is more like a cactus. We can put a tooth or dentine into that environment and expect that it will still survive and join to the body and be accepted as sort of part of that body's own substance. The optic then goes in the center, and the combination of the optic and let's call it the haptic, which is a term that ophthalmologists are familiar with, joins it to the body, and the tooth plus the optic allow the patient to see again.
So there's a clear optic that you put and you kind of drill a hole in the tooth and the tooth is surrounding it. Is that the way it's
Correct,
done?
yeah. The tooth is really just a way to stabilize and position the optic in the front of the eye. And it is a tissue substance that we know will last in that environment for a very long time. And we know that that's not theory, that we know that because the first of these operations in the world was done in the late 1950s. And we have data on this surgery that is 30, 40 years old. So we have, in my own personal journey in training in this operation, I've met with patients who had this operation in the 1970s and are still retaining their functional vision and retaining the tooth on the front of their eye.
Wow. And out of curiosity, do you have any interesting anecdotes from patients and how they respond to this idea of putting a tooth in their eye? What do you feel tends to surprise them the most, or what are some interesting reactions you've heard?
I think that some patients have misheard and it's common for patients and referrers to mishear and misunderstand what we're doing with this. One of the candidates, I met a young fellow in Vancouver who I've had contact with for a long time and has had severe corneal blindness. He asked me if there is anything he should do to maximize his chances of getting his vision back, and I said you should see your dentist regularly to maintain good oral hygiene and allow us the option of harvesting a tooth at some point in his lifetime, possibly to use as part of this operation. That was one of the more unusual pieces of advice as an ophthalmologist that I've given to a patient.
Yeah. So I'd like to talk a little bit about what kind of patients you consider for this. I mean, clearly these are not, routine cornea clinic patients. So can you tell us a little bit more about who are the patients you're thinking about when you're considering OOKP, and what does this typical candidate look like?
Yeah, I think one of the really important things to point out here, and one of the more publicity this surgery gets, the more sort of inappropriate referrals we do receive for this operation. The first thing I say when I'm asked this question is that this is not suitable for anyone who has retinal disease or glaucoma. This will not restore vision if you have significant macular degeneration, if you have significant glaucoma or optic nerve damage. This is really just this operation really just restores a clear pathway of light to the back of the eye, but the back of your eye has to be healthy. In terms of the type of patients who have that severe scarring, this is a rare subset of corneal patients. In terms of the number of patients who might be candidates for this procedure in the whole of Canada each year, we might expect maybe half a dozen every year. We're talking about people who suffer severe thermal or chemical injury, so acid or alkali burns, thermal burns. We're talking about patients who have severe trauma. One of the primary indications is patients who suffer from Stevens-Johnson syndrome or cicatricial pemphigoid, two diseases that cause stem cell loss and destruction of the anterior conjunctiva and corneal stem cell population, but don't affect the inner workings of the eye as much. Those are some of our best candidates. And all patients with severe eyelid loss, tissue loss. Functioning blink mechanism is not a prerequisite for having this operation, whereas it is for almost every other form of corneal transplantation. But those subsets, those groups of patients, those are not common. Those are pretty rare. And so we really are, I would say, the last stop on the train station of anterior segment reconstruction of corneal transplantation.
And is there a clear separation in terms of the indications for, this versus other keratoprostheses like the Boston K-Pro, for example? Is there a clear separation, or is there some overlap? And can you help our listeners understand how you would consider one over the other?
I think that there is a little bit of overlap, but for the most part, most of us understand now who's a really good candidate for one and who's a really good candidate for another. I think the way to choose, the way I ask when I talk on this topic, the way I ask people to think about which K-Pro to choose is to imagine, does the ocular surface that this patient has support the haptic of the K-Pro? In other words, does the patient surf in a Boston K-Pro, for example, does the patient's ocular surface and microenvironment support PK tissue, which is the haptic or the joining tissue for a Boston keratoprosthesis? So for that to be supported and healthy, we need a wet eye, we need a tear film, we need lid coverage or a blink mechanism. And if either of those two things are absent, if you have severely dry eye, a keratinized ocular surface, we go immediately towards or in the direction of an OOKP. If we have a wet, blinking eye, you can consider Boston keratoprosthesis. Boston keratoprosthesis and OOKPs have their own specific other types of complications that you have to take into consideration, but that is the main way we determine which is more suitable. There's a sort of funky middle ground where the patient can blink, but they still have some tear film, and you sort of may debate one or the other. And there are some strategies and tricks that we sometimes employ to do hybrid surgeries. So Boston K-Pros, for instance, with mucosal coverage and some adaptation of the way the surgery is done. But it tends to be those two things, tear film and lid.
Awesome. Thank you. And so for an ophthalmologist in Canada that feels like they have a patient who might benefit from this, what are the actual next steps? How do they go from seeing a potential candidate to getting them evaluated for the surgery?
I think that what I would encourage, the first step I think would be to refer to your local corneal specialist. Have that corneal specialist assess the patient and then make their own judgment about whether that is someone who can be attended to locally with the locally available resources, or whether that is a patient who is surgically beyond more basic operations, more basic options. Within Canada, all of the corneal transplant specialists, we all know each other, and then at that point in time, they will directly contact me with the referral, and that's the way that the general referral pathway usually should go. Referrers who can make direct contact with us, and we have a website and our email contact information is all on there. They certainly can make a direct referral with a letter via the website and the email that is on there. But I usually encourage that the best first step is your local corneal surgeon.
And so at this point, with your center being the main one offering this, is it realistically accessible for Canadian patients who need this? Are there more patients that need it than surgical, spots available for you to take care of these patients? What are the wait times and the bottlenecks at this point?
No, it's a good question. I think that provided we are only servicing Canada, first thing to say is we've set up a philanthropic fund to finance this procedure. We're in discussions with local health services to set up understood pathways of care between provinces. So there should be no barrier for interprovincial patients to receive the operation. And in fact, there's been 3 patients so far from out of BC who we've operated on. At the moment, there is no bottleneck because the flow of patients and the volume of patients, as I said, is not high. When you have a nation of 30 million people, there's no need for more than one surgical center to take care of that volume. Issues may arise. We have requests from international patients. We have requests from the US. And if a decision is made locally to cater to that population as well, then we will have some logistical issues to solve. That has not been so far decided.
EyeCan wants to know what you think. Please send your comments on today's episode or any suggestions you may have for topics or features to communications@cos-sco.ca, and we'll try to incorporate them into future episodes.
EyeCan veut savoir ce que vous en pensez. Veuillez envoyer vos commentaires sur le balado d'aujourd'hui ou vos recommandations de sujets à communication@cos-sco.ca et nous essaierons de les intégrer dans les prochains épisodes.
Hi, I'm Dr. Monique Monroe, and I listen to the EyeCan Podcast.
So we've talked about, the evaluation of the patient, the indications to the surgery and some of the surgical steps. I'd like to move to talking about the post-op recovery. Can you tell us more about what the recovery is like for these patients and what kind of vision is realistic to hope for after this kind of surgery?
The surgery for the patient, and I will say for us as well, like it's a grueling operation. It really is. I think, as far as I'm aware, it's the longest ophthalmic surgery that exists, unless there's something I don't know about. So the patient has to commit to 4 to 6 hours, sometimes longer, general anesthetic procedures, and the occurring over those 2 stages, sometimes with a third stage if we decide we're going to prepare the eyeball in a certain way. So what I mean by that is a patient will come in with no view to the posterior segment. We don't know really what's going on back there. Sometimes our first step is to go in with an endoscopic vitrectomy, assess the nerve, assess the retina, and at that point decide whether we place a drainage tube, a buckle, induce a PVD, apply prophylactic laser to the retina to prepare the eye for the next operations. If the patient is felt to be a candidate, then stage 1 would commence sometimes at the same day, usually at a second day. And that would involve harvesting a tooth with the associated bony root, fashioning that into a rectangle, drilling a hole in that, and then implanting the optic. That tooth is then implanted into the patient's cheek, and then the eye is prepared and covered with buccal mucosa. So all the scar tissue is peeled away from the eyeball, and buccal mucosa from the cheek is used to cover the eye in a graft. So the patient's experience to date has been a lot of surgery with really no result. And then after that stage 1, they may even have less vision than they had before, because the buccal graft is covering the cornea, which was opaque but not totally opaque. 3 months then have to pass, and in that 3 months, the prosthesis will develop a coating, a connective tissue coating. We can't just put stitches through dentin. So we need to have that prosthesis grow in a subcutaneous pocket, a layer of connective tissue that we can actually use to manipulate to pass sutures through. So 3 months later, they come back, and at that point, we take the prosthesis out of the cheek, reflect the buccal mucosa, make a hole in the cornea, remove the lens, remove the iris, perform an anterior vitrectomy, suture the lens tooth complex onto the eye, cover everything with buccal mucosa again, and at no stage in any of what I've just described can we violate the retina or induce high intraocular pressure, either of which can result in total loss of vision for the patient. So it is a long process. After that second stage is done, immediate visual recovery is not usually what happens. Usually there's a little bit of vitreous hemorrhage, and that then takes sometimes 1 week, 2 weeks, sometimes 3 months to fully clear before we really know what the result for that patient is going to be. Of the patients we've done in Canada to date, there's a young man from Toronto who achieved, I think, 20/25 or 20/30 vision 2 weeks after that whole process. This is a young guy who went blind from Stevens-Johnson syndrome when he was 8 years old. He's now 28 years old, and has lived his life in blindness for that amount of time. Now he's doing things that are amazing for us to watch, and include like learning to ride a bike. He has found a job. I called him the other day to check in, and he said, "Sorry, I can't talk. I'm on a Zoom call." So, there's really quite wonderful stories that we've witnessed as that vitreous hemorrhage does clear, and you start to see what their life is like. I recall a patient in Australia. We did a ward round on, who was looking at an iPad. She had gone blind again in 1994, had her surgery in 2017. And her mum was introducing her to her family. She was flicking through photos on an iPad, showing her all of her relatives whose voices she'd heard, but she'd never really seen or knew what they looked like. So the emotional roller coaster can be immense highs and emotional moments for patients and for us as the surgical team. There are other patients who go through that process. We've just had a heartbreaking experience with a young man from Nova Scotia who had a retinal detachment after the surgery, and we can't fix his vision. So this was a high risk eye, multiple surgeries over 20 years. And despite, best efforts in that 12 to 14 hour process, at some point, there was a tear, and, that can be the end of the journey. So it is not an operation that we undertake lightly. It is one that can result in truly life-changing outcomes for patients. When you look at our series in Australia, the 7 patients we did in Australia, 5 of them are still functional vision with 20/30 vision or better, and 2 of them have sort of low vision, count fingers level vision. So it is when we decide to go on that journey with a patient, they have to be fully committed. We have to be sure that there isn't an easier, better option. We have to be sure that there's some potential, some payoff that we could possibly achieve by taking them through that journey. But if and when we do get that result for them, it's one of the most miraculous things that I've witnessed as a surgeon.
Incredible. Really, really amazing. And so if you were to look at, I don't know, a series of 20 or 30 patients, what would you say the average visual outcome that one can expect? Is there a way to put an average to this, or these eyes are so atypical?
We know quite well what the numbers are because of the age of the surgery and the volume that's been done around the world over the time. So like the Italian center looked at their data over 30 years, and they found that at 20, on an average of 27 years after surgery, the chance the tooth was still in position was 92 to 94%. And the chance that the patient still had functional vision equivalent to 20/60 or better was 54%. So for patients who are completely blind with no other option, if you were running a LASIK clinic and you said those numbers, they don't sound good. But when in the world of keratoprosthesis surgery, to tell patients that they have a realistic long-term chance at functional vision, those numbers are sort of unparalleled with other competing keratoprosthesis designs.
And how about on the dental side? Ultimately, it sounds like you need to take a tooth with the roots as well. Are there ever challenges on that end to be able to get a healthy enough tooth, or just the procedural risks of that part of the surgery?
Yeah, there are risks. There are risks that you might create a fracture, a sinus fistula. It's not uncommon for patients not to have good dentition and not be able to, for us to be able to even harvest a tooth that we can use. So in those cases, we fall back to bone grafts as an alternative. Now, bone is a substance that our body does turn over. So we have osteoclasts and osteoblasts, and we build it up and we eat it away. So the long-term survival of a bone as a substitute is good, but it's not as good as a tooth. But that is our fallback, and we sometimes look to that option.
Interesting. And you've talked about this procedure being around for quite a few years. Is it evolving? Is your guess that this surgery would look quite different in 5 or 10 years from now? Or
I
do you
think
think it will still look similar?
I think it's going to look similar. I think that all of the times that very, very many over decades, very many excellent surgeons, outstanding world-class surgeons have worked on this operation. And any time that you try to alter the recipe a little bit, you tend to, in my experience, run into trouble. This has been carefully thought about and planned over a long period of time. What we all hope is that, one day we have something that's less invasive, faster and better, so that we never have to do it again. So that patients with severe corneal scarring could come in and receive something minimally invasive. We've been waiting for that for 70 years. And when we were in Australia, considering starting our program there more than 10 years ago, or 10 years ago now, we looked around and we said, well, should we wait? Should we wait on something? Is there something better that's just around the corner? That means we don't have to put patients through 2 general anesthetic procedures, maybe 3. And had we waited then, our patients would have had 10 more years of blindness. And I don't know of anything else that we're about to receive that's going to change or blow this away. We do hope there will be something.
As I'm listening to you and being a fellow surgeon, thinking about how to organize my clinics and my ORs and the flow of patients and the waiting lists, it's clear that this is not like an easy commitment for you, right? To be able to manage these patients and fit them into, the rest of your schedule, which I'm sure is already challenging to manage. So what kept you interested in the space, and how did you get involved in this and stay involved in this?
No, it's a good question. It is not easy on any one of us, really. It's the UK center that does this work has a full-time psychologist, and I think, and at the moment that's me. I'm it's a big journey that you go on with the patients. We see them quite frequently. You have to coach and manage them through real highs and real lows. And I think the way I got into this was 2 key things. One of them was to have a plastics fellowship and a corneal fellowship kind of made it an easier road because a lot of the steps were sort of familiar. And the second one was real contact with one of the patients when they were young. So when I was a fellow, I'm from Sydney in Australia, but I trained as a fellow in Vancouver for cornea and for plastics. And at that time, we were looking after a young kid with Stevens-Johnson's. He had gone blind at the age of 14, taking an Advil tablet that he took for a sore shoulder at a basketball tournament. And this could have been any kid. This could have been, my kids now I think about it. And at the time we knew then that we didn't have great options. And they traveled around the world and to try to find one. And one of the staff at the time said, well, you've done plastics and you've done cornea. Why don't you go and learn this? And, knowing a patient who needed it and knowing that we could maybe do it was enough to give me a push. And the final thing that pushed me towards it was having a very good friend who was a maxillofacial surgeon in Australia. So the training journey for me was one that I went on sort of with a mate, and we sort of did that together. And it's really that having to look at these, you got a choice. I guess we had a choice as corneal specialists. Do we look at these patients and admit that we can't fix it? Or do we sort of say, we could fix it, but it's just going to require some extra work and effort? And I think the families, it's hard to sort of say to the families, we're not going to do it just because it's more work, right? So it was really a combination of things that sort of, led me to sort of train in it. It is, but you're right. It is, incredible energy that goes into, every one of the patients we go through with this. I think, I've been lucky. There've been moments, where all of that effort is really repaid and you don't, and it doesn't feel like hard work. And I've had coffee and lunch with multiple of the patients we've operated on in Australia when they walk in and they meet me downtown, and we share a meal. I think 2 of the Canadian patients, one from Toronto, one from Vancouver, both took me out to dinner. about a month ago, and we all sat down and had a meal together. They walked in on their own with no one helping them, and they got on a bus or an Uber and went home. And that those sort of experiences are ones that it's very hard to. I mean, we all as ophthalmologists, we're lucky, right? We get to fix blindness in the course of our job, usually with a cataract surgery sometimes. So there'll be patients who come who we all sort of see who have really bad vision. We do a cataract surgery, and we get that wow moment where it's wonderful, and you see what difference we make. The difference in this operation is that they've usually been blind for more than 10 years, usually 20 is not unusual. So it's just heightened work, and it's also, heightened reward.
And why is it that it's such a long delay? Is it because so many other things need to be tried before this surgery can be considered, or
it's
just
incredibly
because of
hard.
the access?
The access is the main thing. Like, it's incredibly hard to get a surgical program for this up and running. It requires a lot of commitment. It really requires institutional commitment. It requires a maxillofacial surgeon who's willing to do it with you, a glaucoma team, retinal team who are willing to do it with you. It requires you to, be masochistic enough to make this a part of your practicing life. So surgical programs for this, they rise and then they fall again around the world. So Italy was the birthplace, and then the surgeon passes away, and now they're just rebuilding their program there. The UK had a robust surgical program, and now that's being transitioned to a new team. Singapore had a surgical program, and the surgeon retires, and they're still having trouble restarting it there. So, as far as I'm aware, and I apologize to my colleagues if any of that information is wrong, but it's mainly finding a surgical center that is established, funded, able to care for international patients via some funding model, and has a surgical team that's experienced enough to provide the operation.
Greg, thanks so much for taking the time to run through those details. I've certainly learned a ton, and I'm sure our listeners will as well. We'd like to wrap up with our lightning round, where we ask you some lighter questions, a little bit more about you. So humor me with these questions, please. So one of the things that's unique about your journey is that you're both a trainee and a faculty surgeon in Australia and in Canada. And so I wanted to start by asking you, what's the thing you miss the most about either living in Australia or working in Australia?
Both. Living in Australia and working in Australia. The thing I miss about living in Australia, the beaches, for sure. The thing I miss about working in Australia is it is a little, there are sort of some easier pathway. I think Canadian public health model is extremely robust, and it's something everyone should be very proud of. But it is hard sometimes to access newer treatments, to push newer innovations in a system that is completely publicly funded, which has to justify expense. And that's the dynamic that is sometimes hard to navigate. But I've found working in both has been systems. I'm very impressed with both systems, but it's the beaches, man. I miss the beaches.
Yeah, I get that. And on the flip side, what is something you enjoy the most about living and also working in Canada?
I love Canadians. I married a Canadian, so I love the people in Canada. I think they're very friendly, and it's a pleasure to care for them. The snow and the mountains in BC are beautiful, and hard to find something that's as good as that anywhere else in the world. Yeah, and just you guys have a great sense of collegiality and fraternity in your ophthalmic community, and I congratulate you guys for what you have, what you've built here.
I feel that as well. I like to hear that. So thank you. And a final question is, what do you think you'd be doing if you were not a cornea surgeon?
I wanted to be, if I'm not a cornea surgeon or not an ophthalmologist.
Either
one. If it wasn't a corneal surgeon, I'd be doing. I thought that I would be doing oculoplastics in country outback Australia. That's what I thought I would be doing with my life. I did cornea by accident. They lost my fellowship application for plastics, and and I had to. I walked around looking for other options to fill my time, and the first place I walked into was cornea unit at UBC, and they said yes. I don't know why, so I sort of fell into this specialty. Yeah, I think if I wasn't doing that, I'd be a frustrated tennis and cricket player in Australia trying to fill my time.
Well, in a way, thankfully, you have that situation where the application was lost, because here you are doing something so impactful and so useful for our patients, and we're all learning from it. So I'll take that as a win.
Yeah, pleasure.
Greg, kudos for all the work you're doing in this field, and thanks for taking the time to share parts of your journey tonight. I really enjoyed it, and I can speak on behalf of our listeners that they will enjoy it as well. So thank you again.
No, great pleasure. Thanks very much.
Thank you for joining us for this episode. We look forward to bringing you more engaging content over the coming months.
Merci de vous être joint à nous pour cet épisode. Nous avons hâte de vous proposer d'autres contenus captivants au cours des prochains mois.
EyeCan wants to know what you think. Please send your comments on today's episode or any suggestions you may have for topics or features to communications@cos-sco.ca, and we'll try to incorporate them into future episodes.
EyeCan veut savoir ce que vous en pensez. Veuillez envoyer vos commentaires sur le balado d'aujourd'hui ou vos recommandations de sujets à communication@cos-sco.ca et nous essaierons de les intégrer dans les prochains épisodes.
Thank you from the Canadian Ophthalmological Society.
Merci de la part de la Société canadienne d'ophtalmologie. Our sponsors for Season 6 of EyeCan are Astellas, Pharma Canada, and Johnson&Johnson Vision. We thank them for their support.
EyeCan is available wherever you listen to your podcasts, and of course, through the COS Practice Resource Center.
EyeCan est disponible partout où vous écoutez vos balados et bien sûr au Centre de ressources pour la pratique de la SCO. Listening to EyeCan counts for unaccredited MOC credits. Listeners may claim 0.5 credits per hour under Section 2, which is individual learning as educational content review, and that can be done up to 30 credits per year.
EyeCan is written and directed by Kim Tytler and produced by John Allaire from Allaire Strategic Works.
EyeCan est écrit et réalisé par Kim Tytler et produit par John Allaire d'Allaire Strategic Works. Some episodes this season will include relevant links and show notes, so be sure to check episode descriptions to learn more. Certains épisodes de cette saison incluront des liens pertinents dans les notes d'émission, alors n'oubliez pas de consulter les descriptions des épisodes pour en savoir plus.
If any of our listeners have topic ideas to submit, please email them to communications@cos-sco.ca, and we will review for consideration.